Now, here's Dr. Larry.
Did you know? Let's go.
You've waited all week.
Every week, we continue to learn how to achieve a better back and ultimately better health.
Live in the WIKB studios, this is Dr. Larry.
Well, thank you for hitting the Plexus Pastor Tim. Hello again, everybody. Okay, let's get it started. Well, as you know, every show builds on the next. Every week, we continue to learn how to achieve a better back and ultimately better health. Now, in case any of you missed it, last week we talked about injections. It was an important week to be tuned in because we learned and defined about precision injections for pain because, let's face it, there's lots to gain. So, here it is again. Bullseye. And injections for your joints, muscles, and spine. How can you best know if whoever's giving an injection hits the target or shot too high or too low? Let's find out in the review of last week's show. Precision injections for pain. Got a question for you. Do doctors go to a shooting range to practice hitting targets? Like, do they set up a spine, load up a bunch of rounds of medications, start squirting at the target? You know, like a military range practicing. Do you ever run into the setup? Or is it more like the old Western style? In medical school, do they put their white coat and stethoscopes on, stand back to back, walk 20 paces, turn around and fire saline solution at each other? And whoever's quick draw McGraw hits the shoulder, knee, or hip passes medical school injection team? I'm half joking, of course. But think about it. We all pretty much have an idea how military trains in the shooting range. And bow hunters, you know what target practice means. And even a game of darts, we get it. But how does a doctor train for injections? Holsters on the side? Do they spin around their finger, practice on syringe simulators? What's up with this? We need to know because a properly placed injection means the difference between pain relief or not. Now, here's a little funny story that I told last week in brief. A patient I sent for an injection of her spine. The doctor showed up and then showed her the needle beforehand, kind of like he was brandishing the weapon. So how do doctors do it? How do they hit the bullseye or miss? And more importantly, who could be a key player to help the physician hit the target? For your joints, shoulders, knees, hips, extremities, for your muscles, the trigger points, and for the spine in different types of areas. Well, let's give a little background on the shooting range. One of the most misunderstood aspects of injection medicine is how physicians are trained to place the needle accurately. From the outside, an injection can appear simple. The needle goes into the body, medication's delivered. But in reality, what clinicians are doing is target practice inside the human body, often aiming for structures that are only a few millimeters wide. So that level of precision requires training, repetition, imaging feedback in some cases. The injection procedures are not simply about inserting a needle, they're about navigating the anatomy. So one key difference in the shooting range is wind, terrain, and movement. The outdoor shooting range. This is close range shooting, but quick terrain changes without always eyes able to be on it. So the training process for injection procedures typically begins during this: medical school anatomy training, residency training programs, procedural fellowships in pain medicine, sports medicine, and interventional radiology, and then continuing medical education in cadaver labs. The learning process develops in three critical skill sets: anatomical visualization, they got to know the terrain inside the body; hand-eye coordination, so you got to be walk and chew gum at the same time, I guess; spatial needle control. So keep those in mind. It's very important as I develop this point because it makes all of the difference. I'll hear patients say, I heard injections are just kind of a Band-Aid, or they don't really last that long. Some of that's true. Injections can be temporary, but a anatomically visualized, perfectly hand-eye coordinated, spatial needle control, sights down, hitting a millimeter or 2 or 3 or 5 of a target. If it hits it and it's a pain spot, it can help alleviate pain and start the healing process and on to the fix. So these skills are refined over hundreds to thousands of procedures. When performing an injection, the physician's aiming for a specific anatomical structure, not simply the painful area though, reported by the patient. It could be, but the true target could be a nerve root. It could be the epidural space in the spine, a joint capsule, a tendon sheath, think trigger finger, a bursa, think shoulder or hip, or a trigger point within a muscle, think like your upper back. Now, these structures, as you know, are not visible externally for the most part, meaning the physician must mentally reconstruct the anatomy beneath the skin. Almost have to have like X-ray vision in a way, although that would even be more helpful. They actually have to create it, theater the mind. So contemplate that. Visualizing not visible structures, that requires years of development, and this is where another key practitioner who has the market cornered to help them out in certain cases, which I'll tell you who that is in a minute. You already know, though. And the ability is developed through this years of this anatomical training and procedural repetition. They also practice in cadavers. So a major component of injection training occurs in cadaver laboratories. It allows the physician to practice needle approaches, observe real anatomical relationships, understand tissue depth and angles, and see how structures shift within a body positioning. I'm going to go back to the tissue depth and angle. There's a really interesting story that I want to share with you that I want to get done in this review if I can, about tissue depth and angle and a patient that had to have some fluid extracted out of a hip. I'll tell you that in a second, hopefully. So the sessions help clinicians with the three-dimensional anatomical awareness. Contemplate that. We hear it again. Anatomical relationships, depth and angles, shifting structures. For many procedures, cadaver labs are the first environment where physicians perform the complex needle placement. And by the way, a sidebar comment, in chiropractic school, we spent over a year on just cadaver labs. Started with a full cadaver. We had to respect and resect with the surgical scalpel and other tools so we could learn the anatomy hands-on, three-dimensional. And our incisions and resections had to be very precise as well. Needle trajectory training. So one of the most critical aspects of injection medicine is needle trajectory. The physician must determine the entry point to the skin, angle of the insertion, the depth required to reach the target, and the structures that have to be avoided. For example, when targeting a nerve root, the needle may pass near bone, ligament, blood vessel, nerve tissue. So the physician must guide the needle through this path with extreme control. Even small changes in needle angle can change the final position by several millimeters or more. So this is why, by the way, some patients feel injections as it's passing through or even grazing by other anatomy. Whoa, I felt that one, is sometimes what I hear. Thankfully, with modern inventions, we have image-guided training as well, too. One of them is a live X-ray called fluoroscopy. This allows the physician to observe the needle advancing toward the target in real time. It teaches the operator how to position the needle as it correlates to the internal anatomy. Then there's ultrasound. This provides live visualization of muscles, tendons, blood vessels, nerves, and joints. So this technique is widely used in sports medicine and other musculoskeletal procedures. Now keep in mind, this is still a blurred vision of reality. It's like putting somebody else's prescription glasses on and looking around the room. You know it's a table over there in the room. You know it's a lamp in the corner, but it's a blurred vision of what that is. That's kind of what ultrasound is like. And then you got CT guidance injections. Then there's contrast guidance injections, which I went over last week. Kind of an interesting story about how a doctor that I had on the radio about 3 years ago, how he uses dye to figure out how much more tissue he should pull out of a spine. So kind of not an injection, but I tied it in last week just for illustrative purposes. So the repetition experience becomes really important, like any technical skill. Physicians who perform injections should and regularly develop tactile feedback, what it feels like, anatomical intuition, faster procedural efficiency, and more consistent needle placement and accuracy. So as they develop their skills, the tactile feedback becomes even more important, which is an overlooked component of how, when a physician is injecting something, let's say a shoulder, what things feel like. So, for example, a couple little interesting points. Muscle tissue offers moderate resistance. Ligament tissue feels denser as they're going through. And joint capsules create a pop sensation when the needle is passed through. Then, of course, there's the avoidance training, what not to hit. And I went through all that last week. And the importance of precision. So, in summary, just to kind of keep this in your mind when you're going to get an injection, or you may have to get an injection, or you know somebody it is they've got to develop the expertise in three-dimensional anatomy, the needle trajectory and control of the needle, image-guided targeting, tactile or sensory or feel to the tissue, and of course the safe procedural pathway. That's it. Does that sound good? Call it a wrap? I feel like, that satisfied the equation. If I just stopped there, I could have squared in the show, and you would have been like, okay, that's a little more depth and knowledge. It's not just going in there, getting a needle, and off I go. And it could have satisfied it. But ultimately, and in the majority of the time, I say yes. A well-trained seasoned physician can hit the spot, bullseye, or at least get near it. And occasionally, if not, they regroup and try a different spot. But what if they don't? What if you thought the injection failed, and so did they, but in reality, they didn't know that they missed the bullseye? It happens. What if an additional asset could be used? This one additional key player who could and can work alongside case by case to help drill down within millimeters of precision, literally split hairs of accuracy for the injection. So therefore, your injection has an even higher level of success. More importantly, the one key additional practitioner to help hit the target. Unfortunately, physicians are not trained to participate with this practitioner because they don't know that this practitioner can assist with precision, unless it's shown to them. Therefore, it is literally only known to you, the patient, and the physician if it's showed to them on a case-by-case example. And this helpful person can be your chiropractor, who can help put an X on the spot. I literally have a marking pen at my office where if somebody's going to an injection and there's a collaboration with the physician, I will X marks the spot. Where does this make a big difference? How about a lady who had left shoulder pain, had an injection on the back aspect or posterior aspect of her shoulder, it failed, didn't work, sent her for a round of injections. I re-examined the spot, called up the doc and said, hey, how would we try a front left at this location, at this angle? He pulls up the image. He said, it doesn't look that bad on imaging. I said, yep, but that's what the pain generator is right now, and this is the exact structure. I detailed it out for him. He proceeded with the injection, and the lady had a year of relief. Big difference between a failed injection and a successful injection. That is the asset of your chiropractor, could help. Now, there's some other elements to that. They have to be willing to call the doctor. They have to be willing to, if they're just the rack 'em and crack 'em chiropractor, or they use other instruments and not their hands, and they haven't developed that tactile sense, and those types of chiropractors typically aren't going to be your best asset. But those that are the hands-on chiropractors, the examiners, the ones that adjust you or are feeling muscles all along the way, they develop those three-dimensional tactile sensations that really can help out when it boils down to injections, especially in other anatomical areas like shoulders, even X mark spots on thumbs for doctors, muscle tissue. It's kind of a fun thing to do because the result is the patient, you, gets better. There was more. However, if you missed the entire show and want to be more in the know, then log on to my website, drlarryradio.com, hit the subscribe button, follow the links, and listen to the show. It's been uploaded now, which you can listen to at your leisure as a podcast. And here is the final point. If you have pain and need a shot, just remember it's about hitting the target or not. Now, beyond that, in addition to the shot jocks, last week we learned a simple self-test for pinky nerve. It was another Dr. Larry cool tool, and you can call my office for a freebie reminder just in case you're in need of a retip or a tip up. And so that was last week. Hi-ya. Now today, we'll forget that monologue for a moment and keep remembering those mandatory communication skills all doctors must have, which are inquisitive listening and staying positive. Again, it often means the difference between sick and well. Also, it's another month of the year, so let's keep our legs in gear. So in our tip and trick segment today, we're going to learn, Tim, I say that my brain went into a whole another direction. I know you work out, right? So this guy I worked out with, who's old roommate back in the day, we always like, when we did legs, we go, oh, it's time for legs day. Time to hit legs. And so we had this funny, like, Hans and Franz. Yeah, SNL. Yeah, exactly. So that just hit my brain. So, and here, sitting over here, workout. So did you do legs this week? Yeah. Did you hit legs?
Squats.
You did squats? Okay, good. So, of course, you snap into a Tim after your legs day are calling out right from the broadcast booth while we crank up the tunes. And I hit the center stage for the demo. However, before all that, in order to have good health, you don't need a lot of wealth. So let's flex our forebrain and put some knowledge to the game. Because today, we're going to talk about, hit it, Pearl.
Dr. Larry brings you another segment of Did You Know?
Neuropathy. Neuropathic. Nerve suffering. Nerve sick. Sick nerves. You have nerves that are not feeling well. Your nerves are not pinched, they are ill. So, can neuropathy be cured with a pill? It's neuropathy. What you need to know when we get back from the break. Stay tuned. You're listening to the Dr. Larry Radio Show.
Dr. Larry will be back in a moment.
What's cooking in your community? Head to one of these fine establishments for your next bite or beverage.
Alpha Michigan Brewing Company on the Circle in Alpha opens at 4 Wednesday through Friday and noon on Saturdays and Sundays. Call 920-358-9551 or go to alphamichiganbeer.com or Facebook for tap menu and events.
The Habit Bar and Grill, Highway A in Nelma, Wisconsin on the Snowmobile Trail and offering premium gas and daily specials. Open 10 a.m. 7 days a week. Call The Habit, 715-545-2646.
The Horseshoe Bar, downtown Amosau, opens at noon, 7 days a week. Burgers, sandwiches, nachos, crazy broad specialty homemade pizzas, and deep fryer snacks, too. It always tastes better at the Horseshoe Bar, downtown Amosau.
The Local Eats List from your friends at WIKB WFER.
This is Clovis from Iron River. You're listening to Dr. Larry's Radio.
Does your financial advisor take the time to really listen to you? Is your financial strategy personalized to you and your family? Will your financial advisor be there as your life and financial situations change? When you work with Ryan O'Grady, your Crystal Falls Edward Jones financial advisor, he focuses on what's important to you. You work together and use an established process to create a personalized financial strategy, backed by the advice, tools, and resources to help you reach your goals. And you can partner long-term to help your strategy stay on track. Contact Ryan today at 906-875-3833. Edward Jones, member SIPC.
This spring, your home is ready for a makeover, and Jensen Akins Hardware and Appliance has the deals to make it happen. Don't miss our Spring into Savings event with big discounts on garden tools, outdoor lighting, and appliances. Come in, get inspired, and spring into your next project with Jensen Akins, your hometown hardware and appliance experts. That's Jensen Akins of Conover, of course.
Breaks over. Time to get cracking once again with Dr. Larry.
Welcome back. Neuropathy. Neuropathic. Nerve suffering, nerve sick, sick nerves. You have nerves that are not feeling well. Your nerves are not pinched, they are ill. So, neuropathy. Why it happens, why it persists, and why so often do people struggle to get better. I'm going to give you the flow of the show here. I got to rattle off some points. We're going to go over neuropathy, why it's misunderstood. It's not a new thing, but the understanding has evolved a bit. And I'm not quite sure if that's helped. So I'm going to try to frame that in for you. I'm going to define it for you, explain the nerve itself. I'm going to explain the difference between a small and large fiber, why symptoms start in the feet, the modern rise of neuropathy in diabetes, pre-diabetes, obesity, and activity. I'm going to go through a couple causes. I'm going to try to differentiate for you neuropathy versus radiculopathy versus entrapment. Explain why treatments oftentimes are disappointing. Symptom control versus nerve repair. Some metabolic lack of recognition, best way I can say that. Fragmented care mismatches, irreversible damage in some cases. And then I'm going to kind of wrap this all up with some better framework and end with some flat out truth for you. So neuropathy is one of the most misunderstood conditions really in modern healthcare. You're told you have neuropathy. You're given a medication, you may get a test, you see multiple doctors, and months or years later are still asking the same question: why isn't this getting better? And it's a fair question. Because neuropathy isn't just a pain problem. It's not just a numbness problem, and it's not necessarily just an aging problem. And it's not one simple disease. It's often the first visible result of a much deeper process involving metabolic issues, blood vessel compromise, inflammation, nerve fiber injury, and sometimes a mixed bag of diagnosis. So fundamentally, diabetes remains the most common overall cause of neuropathy based on those factors that I just told you, and it commonly affects the feet and the legs first, and sometimes later involves the hands and the arms. And it's not necessarily new. People have been plagued with this for as long as we've been around. It's just how we understand it, and also why it's growing, not necessarily always in awareness, but why we're having an increase in cases. Clinicians reported patterns of burning, numbness, weakness, gait instability, and sensory loss as far back as we can see as far as medical records go. Imagine doing a medical record trying to chisel on a rock or something like that, or like an ink pen with a feather. Oof. And what they lacked, though, was just kind of the modern way to frame it. In early understanding, people recognized the symptoms. They just didn't understand the structure of the nerve until, of course, anatomy and physiology came along. As the anatomy of the nerves and understanding matured, healthcare became a little better in identifying some of the disorders that involved neuropathy. In modern times, clinicians link together neuropathy to identifiable causes, such as diabetes, as I mentioned, so you hear me repeat that, excessive alcohol toxins, other toxins, nutritional deficiency, inherited disorders, but don't let, it's in my genes. I see that kind of a whitewash diagnosis now, and it's not the patient's fault. It's used too lazily in healthcare. You probably inherit it. And then, see, I got it from mom, dad, and on the gene pool we go. It's not always a genetic thing. In fact, it's less so. Compression and other systemic diseases. So with the addition of electrodiagnostic testing, the stuff with the needles they hook up into your legs and arms and send signals through, it could be moved a little bit more into a descriptive format of what actually neuropathy is. So what changed, though, is the understanding of it. The condition is the fact that the nerves are sick. They're not well. And it's a disease process. It is damage to the function of the nerve outside of your brain and your spinal cord. It means the problem is affecting the nerves outside of the brain and spinal cord the most. These carry sensory, what you feel, some of it motor, how you move, and some of it as far as the automatic information or autonomic information that's given feedback that you just don't have any control over. This is why neuropathy can produce a surprisingly wide range of symptoms. And it matters because the burning, the tingling, the numbness, and the altered temperature sense, plus pain, then the weakness, the muscle loss, and the gait dysfunction, then the other issues that come along with it. So that's why it's just beyond the feet in a way, and it can be a systems problem or a systems sickness. Now, I say sick, and we think temperature with a thermometer. No, but it's a sickness to the nerve, and that's why I'm saying it this way a little bit differently, so you kind of understand it in that context. So what's being damaged? Well, you have to understand a little bit, a small smidgen of the anatomy of the nerve. So a nerve is not one single strand. It's a living structure. It has multiple fibers. It has connective tissue layers. It supports cells and blood supply. So to simply say this, it has three main components. Of those three main components, One of them is the wire, and the job of the wire is to carry the electrical information from one place to the next. It is metabolically active. That's a very important component to all this, because neuropathy can be a metabolic problem. It depends and needs energy. One part of the nerve needs blood flow, and it also depends on a healthy internal environment and neighborhood. So when this part of the nerve, called the axon, is damaged, the signal becomes weaker, slower, and distorted or completely lost. In length dependency as well too, so the longest nerves are the most vulnerable. That's why it hits the feet first, or the hands second. That's why those symptoms are. So when someone has nerve damage or nerve sickness, the problem is not merely just an irritation. It can mean actual structural problems to the nerve and the fiber itself, which reduces the quality of the transmission and advances the disease and reduces the function altogether. It's a huge reason why patients get frustrated. Once this component, this one aspect of the fiber of the nerve becomes lost, structure, damage, improvement becomes slower, less predictable, and sometimes incomplete. Another part of the nerve is the sheath part. This is the insulation around the nerve. It helps the signal travel quickly and efficiently. If that's injured metabolically, the signal may slow, misfire, or fail. So now if you're hearing this, you know that we can go in modern medicine and give you a hip replacement. We can give you carpal tunnel surgery to fix entrapment, which we'll get entrapment here in a little bit. And as I suspected, this is taking me way longer than I thought, and because it's a monster of a subject that I'm trying to drill down for you, so I might have to split this up into 2 shows. But we can't go in necessarily, take a nerve out and replace it with a new nerve. Your nerve is nerve. That's why neuropathy continues to perpetuate and exist. It's a sick, diseased, damaged nerve that is not replaceable. So you got to deal with the damage. Root cause we'll get into here in a second. So the sheath part plays a role. Then the nerves depend on very small, intricate, delicate blood supply. This is one of the most underappreciated points in neuropathy. A nerve is not just an electrical structure, it's a living tissue. Living tissue depends on oxygen, nutrients, and circulation. So in the case of, let's say, diabetes, or forget diabetes, when the nerve itself has become sick, diseased, or damaged, it's not just necessarily the fact that, I got my nerve itself is the problem. How do I fix the nerve? And that's kind of like the elusive question. The nerve gets damaged over time. High blood glucose, high blood fats can damage the nerve. Other complications can tie into these vessels, where the vessels themselves start to become damaged in and of themselves. So the blood supply gets robbed. How does that happen? Poor diet, lack of exercise and movement, reduces blood flow slowly over time, more sedentary, and that's when the damage starts to happen. So if the blood supply is impaired, the nerve is underfed. If the metabolic environment is toxic, the nerve is stressed. If this goes on for years, the nerve gets sick. And that's why neuropathy is not purely a pinched nerve discussion. A lot of neuropathy is sick tissue problem. So hopefully I've separated that enough for you right now. I'm on part 4 of about 20 parts that I want to go over with you. And I'm going to try to move through these parts a little quicker right now, because hopefully we can start to understand this neuropathy a little more clearly. Here's a common phrase I hear: my tests are normal, but I still have symptoms. Well, there are large fibers and there are small fibers as it relates to the nerve. The large fibers help with vibration, position sense, some aspects of touch, and some aspects of motor. Small fibers help with pain, temperature, etc. So the large fibers carry the vibration while the small fibers carry the pain and temperature. And why this matters clinically. You, the patient, can have burning in your feet, altered temperature sense, strange pain, and other symptoms and be told routine tests are normal. That does not always mean nothing is wrong. It just means the disease is affecting the small fibers early or the small fibers selectively. And this is a major source of frustration with neuropathy diagnosis, and neuropathy care. So the small fibers get nailed first in some cases, and then the large fibers. The pattern then, most commonly, as I said earlier, is the length-dependent neuropathy. This usually means symptoms start far away first, feet, then legs, lower part of the legs, sometimes hands later, often symmetrical, so that's why like both feet, both hands, often gradual, often worse at night. The further the nerve has to travel, the more vulnerable it becomes. This is why the feet are affected first. Now, why is this increasing now? So neuropathy seems to be exploding, or more people know it, because conditions that damage the nerves are widespread and growing themselves. In 2026, according to the CDC, the stats on diabetes are this: 40 million people in the U.S. have diabetes. 115 million people, or adults, have pre-diabetes, and more than 8 in 10 have pre-diabetic symptoms and don't necessarily know it. Obesity reports right around 40% between August of 2021 and August of 2023. So this environment alone, just that alone, diabetes and pre-diabetic, sets up the nerve to be sick and diseased. Do all people who have neuropathy have diabetes or prediabetes? No, but a big chunk do. Peel that away, and let's say you are not that, but let's say you have a depleted metabolic environment. What do I mean by that? Low nutrient dense diet, low physical activity. That sets up the same environment. So the modern nerve then is living in a blood sugar dysregulation, insulin resistant, high fatty triglycerides, chronic inflammation, physical inactivity or low activity, and micro or small vascular stress. That's what happened. So basically the nerve lives in a bad neighborhood. And that bad neighborhood is metabolic high crime area. What is metabolic? It's the total of all chemical changes that take place in a cell or you, the organism, to produce energy and the basic materials needed for the processes of life. That's a broad definition. What is metabolic dysfunction? As it ties into neuropathy, it is a breakdown, a destruction, and a sickness in the body's ability to manage energy efficiently, often resulting in much or too little essential substances, sugar, fat, etc. The core driver is driven by insulin resistance, where cells fail to respond to insulin, leading to high blood sugar, potential weight gain, and now we start to have the destructive process happen over 5 to 15 years. That's the environment. Diabetes is not only the cause, but this is the environment of the cause. So those are some of the things that create the sickness. Now, the confusing part is what's the difference between neuropathy, radiculopathy, shame on the words of these, and entrapment neuropathy. Oh boy, Dr. Larry, you had me. I was following you until you just started saying this. Now I'm derailed. It's 12:39. I got to get back to work. Sounds interesting. How many more parts do you have? Can you circle this back around and help? Hang on there. I'm going to throw you a life jacket. Forget the term radiculopathy. This is your basic component where a nerve in your back or your neck radiates outwards and follows a specific pattern. That's where your musculoskeletal doctors can and should differentiate for you between neck or back, spine-related pain that causes numbness and tingling, and some of the symptoms you just heard that are neuropathic or neuropathy symptoms, but it's actually coming from something out of the spine. Entrapment neuropathy is something equivalent to carpal tunnel. Something's trapping the nerve, it's got to be released, causes numbness, burning, tingling, all that kind of stuff you think about. That's an entrapment. That usually can be smoked out with diagnostic testing, exam, and locating where the problem is and fixing that. Again, I use carpal tunnel as a simple example. So entrapment neuropathy and radiculopathy, when it comes to those patterns, those two should be, by a skilled practitioner who knows what they're doing, able to differentiate those when it comes to the compare and contrast between all three of them. So I guess my point is this. You shouldn't have to worry too much. You shouldn't have to worry too much and go, oh, is it coming from my spine? Or is it coming from something else? Or is this really neuropathy? If you have a good team of people that are working with you, because they should be able to exclude the other two out right away or within a period of time. So don't worry. Now that also unfortunately goes back to the fact is that's why not necessarily can chiropractic help you directly with true neuropathy. Now that said, if you got numbness, tingling, burning, hands, arms, and you're not sure if it's neuropathy or if you got a vague diagnosis, well, then your chiropractor is a great person to talk to say, hey, this is coming from your spine or not, and they can really nail it down for you. So again, it's not that you shouldn't go, it's just sometimes they can help differentiate the diagnosis for you. Said another way, not every numb foot is neuropathy. Not every burning hand is carpal tunnel or neuropathy, and not every leg symptom is a disc. What you have to ask yourself now at this point in time is, and have to understand, is if you have true neuropathy, this is a sick nerve that has to be healed. So I've got to cut to a commercial break. I'm going to come back. I have to take pieces of this out to fit it all into the show. Like I mentioned, I forewarned, this is a bit of a monster of a subject here that I'm trying to line up for you. When we get back from the break, I'm going to kind of wrap up a little bit of what I just talked about, re-outline it for you, and then I'm going to help you understand what you can comprehend as what could be, I don't want to say fix, that would be inappropriate, to help offset some of the progression of the sick nerve and elongate the process so that therefore the nerve slows down what it's doing and not necessarily, unfortunately, fix it. We'll do that when we get back from the break. Stay tuned. You're listening to the Dr. Larry Radio Show.
We'll be right back with Dr. Larry.
Here's your Iron River and surrounding area forecast. A flood watch remains in effect. 70 this afternoon under clear skies, northwest winds around 5 miles per hour. Clear skies again tonight, lows dip down to about 48. Chance of thunderstorms tomorrow, highs level off around 70, partly cloudy skies. From the Weatherology Weather Center, I'm meteorologist Jennifer Wojcicki on WIKB. Right now, it's 64 degrees.
Stevens Real Estate has been the top producing real estate company ever since 2009. With convenient locations in Iron River, Florence, and Iron Mountain, buying and selling real estate has never been easier. Our team of pros is your team of pros, trusted since 1979.
I got injured in a co-ed soccer league. They immediately told me that I'm going to have to speak with an orthopedic surgeon. My first thought was OSMS. I knew they worked with athletes in the past, and I knew that they had really good orthopedic surgeons. The team at OSMS really were all on board with getting me back to what my life was. My goals were their goals. I wanted to get back to my best, and they wanted the same thing for me. It's amazing that I can still do what I did before. I'm back thanks to OSMS.
Break's over. Time to get cracking once again with Dr. Larry.
Welcome back. Neuropathy. Neuropathic, sick nerves. Not injured nerves, not pinched nerves, diseased or sick nerves. They're not well. So, the pattern for neuropathy is typically symmetrical, both on one side. Remember 3 parts of the nerve itself. The long parts of the nerve are the longest nerves, the ones most effective. You've got the oxygenation, the circulation to the nerve itself that becomes diseased and compromised. And the deficiency of that sets up the neuropathic or neuropathy process over time. You don't typically know neuropathy is going on until the symptoms start appearing. So said a different way, when the symptoms start, roll back the clock 5 to 15 years. My feet feel numb, burn, tingle. It's something's going on. Maybe it's the small nerve fiber, undetectable, only detectable by the symptoms. Throw in some labs in between there as well. But still, even with that, the bounce around effect starts to happen. Typically, it's this. My doctor says I have neuropathy and they gave me gabapentin or some type of other nerve pain medication. That's all they said they can do. And then they ramp you up to, titrate you up to 3,000 milligrams a day, I think in certain cases I've heard. So that's 300s, 3 times a day. So do the math, 900, so about 2,700 milligrams a day, maybe, and then add in another one there, 3,000 milligrams. I think that's the highest I've heard. And what is the medication doing? It's just dulling the pain part of the nerve. It's not fixing the nerve. Oftentimes, and I understand with communication, sometimes we have to be a little bit theatrical when we're talking to patients about like what's going on. We'll say, okay, this medication, or doctors will, this is for your nerves. Well, without a constructive critical thinking to that, you would think, I'm getting a medication for my nerves. Gabapentin is not for your nerves in the literal sense. We can say it's for your nerves, but it just helps out with the neuropathic pain side of it, which does zero for the metabolic disease component of it. So keep that in mind. And I also feel bad too because, boy, there's a lot of claims out there, especially with, there's a lot of ads and claims. Do you have neuropathy? Then take and just get inundated with, different types of supplementation, different types of protocols, etc. And it just completely bypasses. They're trying to sell you something, okay? Clearly, they're just trying to sell you something, with the hope that out of the some that take it, some will get better. So realistically, doing this show is to give you an understanding of the depth of the sickness and the disease of the nerve itself, and to not be too hopeful or assume that a supplement A or B or this pill or not pill is going to fix it, or if there's something in the works right now, because it is a metabolic disease process to the nerves, and that is also where some of the help can be there as well too. But you have to understand the metabolic disease process. Okay, high blood sugar, insulin resistance, inflammation, poor circulation equals sick nerve. That's the environment. That's the bad neighborhood. The one strategy is to stabilize blood sugar and improve your circulation. If you walk away with those 2 points, stabilize blood sugar, improve circulation. So it's not necessarily a single most important pill. It's not a single most important procedure. It's not a single most important supplement. It's your daily physiology that matters. Even the best medications just quiet the nerve a bit. They don't fix the environment. The environment has to be fixed. Controlling blood sugar swings, avoid large blood sugar spikes, build meals around protein and fiber, eat consistently and avoid chaotic eating patterns. So the goal is steady, not spike. You want to move your body daily. Telephone time at a walking pad for sale for $50. Walking pad, things of that nature. There was a study done, I didn't pull it in the notes for today, so you're just going to have to believe me, but about how to improve circulation. One way to do circulation for especially like lower extremities is a vigorous towel rub after a shower. So you're heated up, you have your shower, your bath, you take your towel and you start at the lowest part of your legs, and you basically take, with both hands and kind of work behind your calf and in front of your leg and work all the way up to the leg on both sides. And of course do that. It's hard to do it on your arms, but it's easy to do it in your upper trunk as well too. That vigorous towel rub for a few minutes helps stimulate circulation. You can do stuff like that daily. That will stimulate blood vessel growth as well, in addition to some other things to stimulate circulation. So keeping low blood sugar, improving your circulation if you have neuropathy symptoms, and if you don't, then you're in the 5 to 15 year process of the environment where it's being created. Those are some of the things that you have to start to do to help alleviate the progression of the disease or start to reduce some of the symptoms, but not eliminate them. Inflammation is one of those things too to keep at a minimum. Your nerves need blood flow to survive. Chronic inflammation irritates the nerves and restricts blood flow. So the environment is such that what you have to change, your nerve isn't broken in isolation, it's reacting to the environment that it lives in. You have to start to change the environment and give the nerve a chance. Simple daily checklists. Did I keep my meals stable today? Did I move after eating? Did I stay active in some way, shape, or form overall? Did I avoid major sugar spikes? Those are the things that can help. You're set up for unfortunate for failure. I got to wrap this one piece up right now. The visits nowadays in healthcare, as you know, they're short, fragmented visits. There's insurance limitations. There's incomplete visits. Patient expectations are shaped by quick fix culture, and these conditions are biologically hard to reverse. So really the better way to frame this is neuropathy treatment often fails to match the complexity of what's going on in the disease process itself. That's why there's a lot of disappointed patients out there. So keep that in mind. Kind of wrap your mind around the fact what we went over today. I did have to condense it even further than I thought. Hopefully, and maybe what I'll do is I'll revisit this again, hit it at a different angle as I tend to do because I've never done neuropathy before. Thank you, listener, for bringing this up to me to go over it. I guess I started the process that I haven't finished yet. We'll try to go over it again, like I said, in the future. And by the way, keep those comments coming. If you have shows you want me to do, if you have questions, I'll give you the website again, too, to log on on WIKB to help out and bring up some other topics that I can do on the air. Okay, upcoming commentary and our tip and trick of the week after the break. This is the Dr. Larry Radio Show.
We'll be right back with Dr. Larry.
Does your financial advisor take the time to really listen to you? Is your financial strategy personalized to you and your family? Will your financial advisor be there as your life and financial situations change? When you work with Ryan O'Grady, your Crystal Falls Edward Jones financial advisor, he focuses on what's important to you. You'll work together and use an established process to create a personalized financial strategy, backed by the advice, tools, and resources to help you reach your goals. And you can partner long-term to help your strategy stay on track. Contact Ryan today at 906-875-3833. Edward Jones, member SIPC.
This spring, your home is ready for a makeover, and Jensen Aikens Hardware and Appliance has the deals to make it happen. Don't miss our Spring into Savings event with big discounts on garden tools, outdoor lighting, and appliances. Come in, get inspired, and spring into your next project with Jensen Aikens, your hometown hardware and appliance experts. That's Jensen Aikens of Conover, of course.
What's cooking in your community? Head to one of these fine establishments for your next bite or beverage.
Alpha Michigan Brewing Company on the Circle in Alpha opens at 4 Wednesday through Friday and noon on Saturdays and Sundays. Call 920-358-9551 or go to alphamichiganbeer.com or Facebook for tap menu and events.
The Habit Bar and Grill, Highway A in Nelma, Wisconsin on the Snowmobile Trail and offering premium gas and daily specials. Open 10 a.m. 7 days a week. Call The Habit, 715-545-2646.
The Horseshoe Bar, downtown Amosau, opens at noon 7 days a week. Burgers, sandwiches, nachos, crazy broad specialty homemade pizzas, and deep fryer snacks too. It always tastes better at the Horseshoe Bar, downtown Amosau.
The Local Eats List from your friends at WIKB WFER.
This is Clovis from Iron River. You're listening to Dr. Larry's Radio.
Does your financial advisor take the time to really listen to you? Is your financial strategy personalized to you and your family? Will your financial advisor be there as your life and financial situations change? When you work with Ryan O'Grady, your Crystal Falls, Edward Jones financial advisor, he focuses on what's important to you. You'll work together and use an established process to create a personalized financial strategy, backed by the advice, tools, and resources to help you reach your goals. And you can partner long-term to help your strategy stay on track. Contact Ryan today at 906-875-3833. Edward Jones, member SIPC.
This spring, your home is ready for a makeover, and Jensen Aikens Hardware and Appliance has the deals to make it happen. Don't miss our Spring into Savings event with big discounts on garden tools, outdoor lighting, and appliances. Come in, get inspired, and spring into your next project with Jensen Aikens, your hometown hardware and appliance experts. That's Jensen Aikens of Conover, of course.
Break's over. Time to get cracking once again with Dr. Larry.
Welcome back. Cotta. Remember that show, Tim? Welcome back, Cotta?
Oh, yeah.
Yeah. Okay, a couple things before we wrap up the show and get to the weekly tip and trick. Prior authorizations and strategic denials. I went over this last week. I want to hit it again for you. Over the past 5 to 10 years, U.S. insurers have increasingly used prior authorization systems and technical denial codes as administrative controls to limit payments. The strategy is not simply a clinical review. It functions as a financial gatekeeping mechanism that slows payments, reduces claim approval rates, discourages appeals, and transfers administrative burden to providers and to your pocketbook. Analysis shows that a meaningful percentage of claims denied initially are later paid if appealed, indicating the denial system often functions as a delay in attrition management rather than purely medical necessity review. So prior authorizations had a decent start. It was designed to ensure that expensive treatments were necessary, specialty medications were necessary, or high-risk procedures were necessary. And they are needed to be clinically justified before treatment. Historically, it was limited to advanced imaging, specialty drugs, and those types of surgeries. What it's become now is being applied to routine services. Routine services. Big orthopedic clinic, chit-chat with one of the docs, January of 2026, comment to be, we're having a major problem with prior authorizations from insurance companies for routine services. Now, I say routine services because those are supposed to not have prior authorizations to them. So all they did, they capture your premium, and they bury in legal language, and then they make prior authorizations necessary for routine services, which should never have prior authorization to them anyway. It's house, and they can make up the rules as they go along. What that then does is limits what can be done on a routine basis for you. So then you have delayed care. 94% of physicians report care delays due to these new prior authorization things. 33% report serious adverse events from delays. It was a bad story. I didn't want to repeat the story about a prior authorization delay that caused a situation for somebody local, because you might know who it is, but bottom line is the prior authorization was purely incorrect on this case, should have never been involved, and it caused a problem with the patient. So anyway, and that was on a large scale. So many providers don't appeal, and and because it requires time, staff, etc. So this is the environment that's going on right now. When you hear the term prior authorization, it's not like the old term that used to be, oh, this must be for something special. It's for routine stuff now. You, the patient, actually have a bigger voice sometimes than the provider does. So if you run into these issues, you can get on the phone and you can start calling your insurance provider. They actually, in some cases, will listen to you more so than even a big hospital. So keep that in mind. Okay, I've got to wrap this up. Timo, snap into the Tim. Oh, I forgot to give the link, WIKB.com, Ask Dr. Larry, click it, fill it out. If you have a show request, ask me question, WIKB.com, fill out the form, Ask Dr. Larry. There we go. Okay, time for the weekly tip and trick. Well, don't blast us, Tim. Don't blast us. You head up to the broadcast booth. I'm heading out center stage for the demo because today we're going to learn a simple self-test for varicose veins.
Oh. Alrighty then. All right, Dr. Larry's in a sitting position, and he has his right hand grabbing his calf muscle and rubbing it.
That's it. It can't get any simpler than that. If you got pain, numbness, tingling in your calf, one side, not neuropathy, and you feel like a little bump back there, and you push that little bump and it's a sore bump, and as long as it's not hard, you have varicose vein. I check those out all the time. One of the easiest things to detect and tell people, you better go get this looked at, or this is, as you heard me say at telephone time, prescribed a walking pad for a patient, and it helped fix a moderate varicose vein problem. I could do a whole show on varicose veins for you. Mild to moderate, how to fix them, how to make them better. You don't have to just give into it. But the little valves in the vein, they get distorted, and then it traps the blood, and then you have pain and swelling. If it gets damaged enough, you have to have the vein removed. But that's a little simple self-test for varicose vein. Yeah, there you have it. Neuropathy, I did that show. Thanks for hanging along with me on that one. And folks, remember, you can listen to me live right here every week to learn how to achieve a better back and better health. Or if you're having a pain or problem, I'm here to help. My number, 906-875-3215. Have a good day, man on the board. It's leg day. See you next week, everybody.
The home of telephone time and all your favorite classic hits. WIKB, Iron River, Watersmeet, Crystal Falls, Florence. 99.1 WIKB, a listen-up radio station.